of obesity? Any idea what is the definition of obesity?
And deposition of fat.
Abnormal deposition of
Deposition
fat.
of
It is
fat
not normal.
obesity.
Everybody, you have fat, I have fat, everyone of us have fat. But it is the abnormal deposition of fat compared to the lean body mass or a muscle mass. Okay, abnormal excess deposition of fat. What are the common comorbidities you will have are they become
Hypertensive,
diabetic, they
CAD.
become hypertensive, they develop coronary artery disease. Okay, and you must know about the system-wise involvement. What is the pathophysiology, how obesity occurs, and what are all the anthropometric measurements that are used to define obesity and grade. You must know all about OSA and metabolic syndrome. What is metabolic syndrome?
It is also known as a Pickwickian syndrome, sir.
Metabolic syndrome and Pickwickian both are same.
Sorry, sir.
What is the importance of metabolic syndrome, especially in a super obese patient? What is the other name for metabolic syndrome?
Metabolic X.
Also called syndrome X. Okay?
Syndrome.
So it's got 5 components: central obesity, increased LDL, low HDL, hypertension, insulin requirement, diabetes. Out of these 5, if the patient has got 3, then it is called metabolic syndrome. And patients who fall under the category of metabolic syndrome are more prone for sudden cardiac complications, like including sudden death. Okay?
Okay.
And you must know the drug dosing principles. You must know the challenges in the anesthetic management and some clinical situation where we can so obesity is defined as an abnormally high amount of adipose tissue compared to the lean muscle mass, that is 20% or more of ideal body weight. The comorbidities can be diabetes, hypertension, CAD, and decreased life expectancy. Surgical conditions, system-wise, it can affect the RS by say obesity hypoventilation syndrome. That is what is called the Pickwickian syndrome. And usually they have restrictive lung disease. In CVS, they have systemic hypertension, coronary artery disease, congestive heart failure, all these things are there. And endocrine, they may have DM or Cushing's disease or hypothyroidism. So all obese patients, you should rule out the endocrine causes. And GI tract, they can have steatohepatitis, hiatus hernia, gallstone, ERD, and delayed gastric emptying. Musculoskeletal, they can have OA, backache, hernia, joint pain, and malignancy is more common. They may have renal failure, depression, and all those things. These are the why they become obese is given very well in Stolting textbook of anesthesia, in BMR, fat storage, and the imbalance between the hunger hormone and the satiety hormone. That is a very important point that it leads to more of eating and cellular disturbances. And because they develop insulin resistance, they go in for this particular problem. And of course, genetic problems, mutations in the hypothalamic melanocortin receptor is the main reason for childhood obesity, and also mutations in the genes of leptin and ghrelin. Environmental factors is high calorie intake and decreased physical activity, and psychosocial is binge disorders of eating and night eating. Depression also leads to overeating. And what are all the measurements you can do is ideal body weight, also known as Broca's index. It is height in centimeters, minus 100 for men and minus 105 for women. BMI is also called the Quetelet's index, which is weight in kilograms divided by height in meter square. Then lean body mass, it is ideal body weight plus 20%. So the BMI grading, underweight, normal weight, 25 to 30 is overweight, whereas our patient is 52. So it goes into supermorbid obese category. And weight circumference is the one to assess the central obesity. More than 102 centimeters in male and more than 83 centimeters in female. And waist to hip ratio is important to assess the cardiac complications in obese patients. More than 1 in male and more than 0.8 in female. And tricep skin fold also is another anthropometric measure using this Harpend and calibers. Then the clinical criteria for metabolic syndrome, these 5 things: abdominal obesity, triglycerides, high density lipoprotein, blood pressure, and fasting glucose. And this is the WHO classification. And adipose tissue can nowadays be accurately assessed by CT and MRI than any other investigations. And the importance of metabolic syndrome is recognized more and more nowadays. And there is a condition called sarcopenic obesity, where reduced muscle mass and functionality is reduced because the muscles become poor because of more of fat. That is suggested by poor grip strength in the patient, history of immobility. Patients who are sarcopenic, they don't move, but they prefer to be lying all the time and slow gait. They don't walk fast. And preoperative assessment of risk factors must compare the central and peripheral obesity, presence of metabolic syndrome, and if the peripheral oxygen saturation is less than 95% breathing air, then these patients have problem of more risk. And emergency medications like adrenaline and noradrenaline, you have to dose them according to ideal body weight in obese patients if they need them for uh, emergency use. And atropine has to be given only on lean body weight. And there is a scoring system called OSMR as obesity surgery mortality scoring, which is used more than very frequently now. And this you can use to assess this BMI, male, hypertension, age, all these risk factors are taken, and any previous incidents of pulmonary embolism or venous thromboembolism is also taken into that. And when you organize the patient for morbid obesity, you have to organize UOT, and deep vein thrombosis should be assessed and prophylactic measures should be taken. Moving and positioning the patient, you must have appropriate equipment to be able to transfer the patient. So you must use appropriate size wheelchair or trolleys or bed. And whenever possible, patients should maintain their mobility. They can walk to the theater and position themselves on the operating table if the OT is nearby. And gel pad should be used to protect pressure points, especially long duration surgeries. They may develop a pressure sore. So all pressure points should be properly protected. And in the absence of any risk for aspiration, performing an RSI is not routinely required. This is the point that you have to keep in mind. This is the current recommendation. And see, these are all some of the pictures to show you the importance of how this is. These are the classical morbid obese patients, not what we see in our routine practice. So this is the ramp position, and in spite of doing the ramping, they are able to see only the tip of the epiglottis. We have to blindly pass a bougie or something to intubate this patient. And this is the patient after intubation and then lithotomy. This is the patient where you can ask the patient to tighten their hand on the side to identify. The patient themselves can guide you about the iliac rest position. That is the picture to show you how to do that. And you must know all about obstructive sleep apnea. It's an episodic cessation of airflow for more than 10 seconds, which leads to decrease in saturation. So more than 5 times an hour or 30 times per night is considered as risky. And with a stop bank questionnaire and alternate is Berlin questionnaire, is all these things which they may ask you. So on classification between central and peripheral OSA, and the investigations, what you do, and what is the treatment, lifestyle modification, CPAP, BiPAP, and they are sensitive to narcotics and the EC desaturation, and long term they go for biventricular failure because of the increase in the pulmonary pressure. Right ventricle also fails. So this is the stop bank questionnaire which we all discussed. And there is another Epworth sleepiness scale, which is to assess the degree of daytime somnolence. So that will tell you about again another severity of the OSA. And this is the Berlin questionnaire which you use. And OSA with daytime somnolence, with a separate name, it is called OSA syndrome. And so this is the distribution of fat and adipose tissue between a normal and obese patient, and how do you dose the drugs? This is the guideline, and overdosing should be avoided. And this actual total body weight, lean body mass, all these things, these are the commonly used drugs. Propofol, for maintenance, you use total body weight. If you are going to give it as a intravenous infusion, DIVA, you use total body weight. For induction, you use only lean body weight. Midazolam, dexamethasone, atracurium, pancuronium, all are given on total body weight basis. Whereas thiopentone, acronium, cisatracurium for maintenance, rocronium, remifentanil are all given on lean body weight. And vascular access may be challenging. Volume replacement also, you have to give it very carefully. Do not rush fluids very fast. And fluid replacement in obese patients should be based on lean body weight and not on total body weight. And challenges, the mnemonic is a prime minister at a public function, A for airway, so detailed evaluation and planning, including awake fiber optic. So if you are planning awake fiber optic intubation, you must counsel the patient well in advance. Positioning, head up during induction and recovery, and ramp or head position for better laryngoscopic view. Monitors, NABP cuff, EKG tracing, need for IABP, SpO2, ETCO2 temperature, and major cases urine output monitoring also you should include. Agents, you should know about how to do the drug dosing, what volatile anesthetic agent is safe, and neuromuscular blocking usage. So you may have to monitor the neuromuscular transmission also in long cases where you use neuromuscular blockers. Technique may be difficult IV access, need for central line, regional anesthesia wherever possible, but with the caveat that if the regional fails or if it is difficult, you must be able to convert it to GA. So in that confirmation only you should plan for RA. For pain relief, use careful narcotics, especially OSA, multimodal analgesia, fluids replacement on lean body weight mass, avoid rapid filling. Airway management, obese patients, tracheal intubation is recommended technique, and you should have the intubation cart all the time when you have a patient who is obese. Routine fiber optic is not indicated unless a specific reason is identified, and you should have a backup plan. Always agree for that. In cases of front of neck access, it is always better to mark the cricothyroid membrane before starting the anesthesia so that you can easily locate that in case a front of neck access is required. And patient position should always be the head up tilt and ramping position, and the bariatric operating table, it will have a high capacity, the shoulder and leg support. So patients always, when you give the head up tilt, they must have a pad here to prevent them from slipping, and the legs should be bound to the table with the belt. And monitoring, you can use the non-invasive BP in the forearm. Make sure that the tubing is going into the radial artery so that you can get the correct reading. And you must have the ventilators which are will be able to deliver high driving pressure and increase the PEEP to do the recruitment maneuver. And the neuromuscular monitoring may be required, as I said, to monitor the neuromuscular function and recovery. And ultrasound may be useful to locate even the peripheral veins. And see, this is a picture where a peripheral vein has been located and the needle is inserted. So that is used for this purpose also, and it is useful for locating the interspinous spaces in the when you plan for a central neuraxial blockade. And clinical situations, there are different cases like patient suffering from a Colles fracture coming for reduction or fixation, which can be managed with regional, but there is no urgency about it. Or cases with COPD coming for malignancy, that also may be the presentation that is required. Or it may be a straightforward the case for weight reduction surgery, bariatric surgery, and this is the huge. So these are all the methods how you manage that. I will skip all those things because that is not our concern here. So the incisional hernia, this is how the hernia sometimes looks like. See the huge abdomen, this is the hernial content. So you reduce all that and push it back into the abdomen and suture that, then you will have a very tight abdomen which will prevent the patient breathing comfortably. So respiratory distress has to be anticipated. And this is how the abdominoplasty is done. You can see this is the pendulous abdomen. So they excise all the extra fat and tissues and then trim up the whole thing. And this also can cause tightness in the abdomen. So these things, both the things will cause respiratory depression. So this is what you have to remember with this particular thing. So I'll stop there with that.